Welcome to part one of two presentations about anatomical variants. Anatomical variants are very common, so it's important that we're able to distinguish these from pathology and particular fractures. So firstly, we'll take a look at acute versus chronic appearances, and then we will focus on the anatomical variants of the ankle and foot. Here are some of the learning resources used in the creation of this presentation.
Hello and welcome to the Anatomical Variants presentation. Anatomical variants are more frequently referred to as normal variants. But the problem with the term normal is that this implies that there is no pathological consequences as a result of these variations. And that's not strictly true. Some, not all, but some of these anatomical variants are symptomatic, and therefore the term normal is misleading. So what do I mean by anatomical variants? Well, these are variations in the textbook or normal skeletal anatomy. They appear in classic locations, they have distinctive features, and it's important to know and recognise these anatomical variants as they can be misconstrued for pathological processes, particularly fractures. So let's start with the basics. Let's learn to recognise the difference between an acute appearance and a chronic appearance. So an acute appearance, such as a fracture, it's sharp appearing. There's a lucent line. There are irregular features. You will see a break in the cortex. And the adjacent bone is irregular and doesn't have a well corticated margin. Conversely, chronic appearances, things that are long-standing, have well-defined margins. They're smooth. You can see a cortex, and the adjacent bone is equally well defined with smooth cortical margins.
Here we see a nice AP/DP image of the foot with the 5 common ossicles identified, and we shall show you examples of these individually as we go forward in the presentation. And here we are with the lateral view. This time we can see 6 common ossicles of the foot. So again, take a look at the names and we will refer to them individually as we go through the presentation.
Let's look at a radiographic example of os intermetatarsium. This accessory ossicle's name is easy to remember if you can appreciate that inter meaning between and metatarsium pertaining to the metatarsals. Therefore, os intermetatarsium is located between the bases of the first and second metatarsals. And it is easy to appreciate that this could be misconstrued as a fracture pertaining to the Lisfranc joint. However, close inspection should identify that the accessory ossicle is well corticated and there is no disruption to the Lisfranc joint. Therefore, the medial border of the second metatarsal should be in alignment with the medial border of the intermediate cuneiform, and we can see here that that alignment is preserved. So, If you had an exam question, how would you answer it? Where, what and how? So all you need to write is no fracture demonstrated, anatomical variant os intermetatarsium, and that'll do well. Let's move on. Os peronium. This accessory ossicle is located in the lateral plantar aspect of the cuboid within the peroneus longus tendon. It may vary in size, but it's always found in this classic place. And this particular example is quite large. Let's compare it now with an avulsion fracture of the anterolateral aspect of the cuboid. Let's take a closer look. Here we can clearly see that os peronium is well corticated. There's a dense sclerotic line surrounding the accessory ossicle. And if you look at the adjacent cortex of the cuboid, it's dense, smooth, well corticated and intact. Let's look at the avulsion fracture. Here we have a tiny sliver of bone. Let's look at the cuboid now. Here we can see the dense cortical margin. If you look opposing the avulsion fracture, this cortex has been lost. There's lack of definition. So compare the two. Smooth, well corticated, sharp, irregular, loss of cortical definition. So how do we describe this? On the left, where, what, how, no fracture demonstrated, anatomical variant os peronium. On the right, what is it? It's an avulsion fracture. Where? Right lateral cuboid. How? Minimally displaced. Let's move on. Let's look at os peronium on the lateral view. On the left hand side, we can see os peronium residing just proximal to the cuboid. On the right hand side, we have a transverse fracture through the base of the fifth metatarsal. Let's have a look at these two images in closer detail. On the left, os peronium is smooth and well corticated. On the right, we can see that the transverse fracture through the base of the fifth metatarsal is in a different location to the os peronium, which would be located around about here. We can see that the fracture has sharp, irregular margins, and there has been a break in the cortex. So, how to answer the exam question? On the left, where, what, how? No fracture demonstrated. Anatomical variant, os peronium. On the right, what is it? It's a fracture. Where? Base of fifth metatarsal. How? Undisplaced. Os calcaneus secundarus. This accessory ossicle is located adjacent to the anterior process of the calcaneum. On the left, we have an example of os calcaneus secundarus. On the right, we have a fracture through the anterior process of the calcaneum. Let's look at these images more closely. On the left is os calcaneus secundaris. Unfortunately, it's not easy to see the well-corticated margin on the accessory ossicle. However, the clue to indicate that this is a chronic appearance and not acute is to look at the adjacent host bone of the calcaneum. It's a dense sclerotic margin, indicating that this is well corticated. Anything that is well corticated is chronic in appearance. Let's compare now with the fracture of the anterior process of the calcaneum. This is caused by an avulsion to the bifurcate ligament. If we look, it's sharp, irregular, it's a lucent line, and there's loss of cortical definition, indicating that this is a fracture. So, on the left, where, what, how? No fracture demonstrated. Anatomical variant os calcaneus secundaris. On the right, what is it? It's a fracture. Where is it? Anterior process of calcaneum. How? Undisplaced. Os naviculare, or it's also called os tibial externum. However, I think os naviculare is easier to remember as it's adjacent to the navicular bone. There are 3 different types, with type 1 being the smallest in size and type 3 being very prominent and probably fused type 2 to the adjacent navicular. Type 2 has a cartilaginous connection between the accessory ossicle and the navicular. Let's move on and have a look at the radiographs. Here we have 3 radiographs of the 3 different types of os naviculare. On the left is the smallest of the os naviculares, type 1. Type 2, we can now clearly see a space between the accessory ossicle and the navicular. This is the cartilaginous joint space that exists between the 2 bones. Type 3 is extremely prominent. We can see there's no evidence of a rudimentary joint space. This indicates that the accessory ossicle has fused to the navicular. So, where, what, how? No fracture demonstrated. Anatomical variant os naviculare. Os trigononum. If we look at the posterior aspect of the talus, I always remember this name by thinking of a trig sitting on top of a hill. Let's compare it to the shepherd's fracture on the right. A shepherd's fracture is a fracture to the posterior talar process. This arrow is pointing to the joint of fusion anteriorly, and the black arrow is pointing to the joint of fusion posteriorly. Incidental note is of a very large calcaneal enthosite at the plantar fascia insertion and a smaller enthosite at the Achilles tendon insertion. You don't need to worry about it, it's just for your reference. Anyway, let's have a look at these 2 images more closely. On the left, we can see that os trigononum has a densely sclerotic margin indicating it's well corticated. On the right, again, we can see a tiny sliver of bone with irregular margins and no evidence of a cortex. It's not clear to see where it's been pulled off on the radiograph, but we can clearly identify that this is the acute appearance in comparison to the chronic appearance. So, what, where, how? On the left, no fracture demonstrated. Anatomical variant, os trigonum. On the right, what is it? It's a fracture, a shepherd's. Where? Posterior talar process. How? Slightly displaced. Os supratalare. Supra meaning superior and talare pertaining to the talus. So we can see the small accessory ossicle sitting superior to the talus. It's well corticated. Usually if you get an avulsion fracture of the talus, it tends to be slightly more distal. So, no fracture demonstrated. Anatomical variant os supratalare. Os supranaviculare. Similar to supratalare, it's superior to the navicular. On the left, we can see quite a large supranaviculare. There appears to be a cartilaginous space between the navicular and the accessory ossicle. Sometimes there is partial fusion. On the right, we can see an avulsion fracture to the navicular. Let's look at these more closely. As always, when we're looking at accessory ossicles, we're looking for a well corticated margin, and we can see on the host bone that there is a dense sclerotic line indicating that it's well corticated. The lines of the accessory ossicle are smooth. Let's compare it to an avulsion fracture. Here we can see the tiny sliver of bone that has been pulled off. Whilst we can't quite see the location that it's been torn off, we can see that the cortex here ceases, and that would suggest that that little bit there has been pulled off the adjacent navicular. So, on the left, what, where, how? No fracture demonstrated. Anatomical variant os supranaviculare. On the right, what is it? Fracture. Where? Dorsal surface of the navicular. How? Minimally displaced. Let's move on. Os subfibulare. This particular one is responsible for lots of people confusing it with a fracture. Here on the left we have a large os subfibulare, and on the right there's an even larger example of an os subfibulare, but in addition there's an avulsion fracture. Look at the massive soft tissue swelling. Let's look at these two images in closer detail. On the left, we have os subfibulare. It's round, it's smooth, it's well corticated. There's an absence of soft tissue swelling. The host bone of the fibula is well corticated and no evidence of disruption to the cortex. In comparison to the right, here we have a large os subfibulare, well corticated, smooth margins. The host bone demonstrates dense sclerotic line, indicating it's well corticated. But look, there's a tiny avulsion flake. It's sharp, it's irregular, and if we look closely, there's unevenness indicating that the bone has been torn off from this site. The massive soft tissue swelling will also help to guide you towards your diagnosis. So, on the left, what, where, how? No fracture demonstrated. Anatomical variant os subfibulare. On the right, what? It's an avulsion fracture. Normal variant os subfibulare. Where? Tip of the lateral malleolus. How? Minimally displaced. That marks the end of part 1, and I'll see you again for part 2.